Good afternoon. Welcome to we're on Wednesday, right? Wednesday afternoon, BOCC. We'll just get right into it. Can I turn my video on? I can do that. Okay. Kelly, make sure we're doing what we're supposed to. Mental health tax corrections. I'm assuming. No, I talked to them and they're fine. I'm gonna make them sit through it.
Good afternoon, Marin Fox, Director of Corrections. I provided you each with a packet regarding the funding for mental health tax we have in the Corrections Department. I identified 3 buckets of money essentially. So I've separated it out by that. We have mental health officers, the mental health expansion, and medically assisted treatment. So if it's okay, I'll start with the mental health officers, unless there is any
Sure.
desire to do in a different order.
No, go ahead.
I'll give you a little bit of a background on how we got to this funding. These positions were funded as part of the county's strategic plan. I'm sure Dennis remembers that long, arduous process we went through. The mental health issues at the jail were considered one of the long-term goals. So the board approved these 2 positions to be funded through the mental health tax. You'll see that there's some questions throughout the paperwork. Last week, I reached out to the board and asked if there was anything specific that they were going to want to hear about. And so Arn responded with some questions. And so I've incorporated those into our materials. So the first question Arn had was whether the service is immediate. Basically, is it related to a law? And in this particular bucket of funding, no, it is not directly, but we believe it has assisted with creating a safer environment for the inmates and reduce the liability for the county. So just as an explanation of what we have 2 officers that we designate to do this. We actually have 3, but 2 are funded through this that we choose. One of them is right here, Joel Trikel, because they're good at it. They're good at dealing with inmates with high needs. And so we handpick them and they're assigned to the mental health area and with the mental health and medical people. Because they are good at it and because they can see them consistently every single day. So, yep. All of it.
My mic is on now.
Could you repeat your question?
Yeah, I simply asked if the mental health aspect was mental health only, or that included SUD.
The mental health, well, the inmates they're dealing with can have it all, you know, and Joel will talk a little bit about that. It's going to be mental health, medical, SUD, all of it. So it's basically our highest needs inmates, and their mental health touches a lot of them.
I've met some people who aren't on anything, but they're clearly not all there in a bad way.
Mm-hmm.
Do you have those as inmates also?
Oh, yeah. And,
Okay.
you know, I've said to the board, and I think you're all aware, we can't force them to take medication. But I think this consistent officer situation does allow us to kind of work with them day after day, and we have a better success rate in getting people started on medication. It allows us to see if people are deteriorating. Previous to doing this, we would have officers, every shift would be a different officer in there, and every day would be a different officer. So you don't know the baseline sometimes. So you can't tell because that officer maybe hasn't been assigned to that area for a week or a few weeks. And so it's the first time they're seeing an inmate. They don't know that that inmate looks worse than they did the day before.
But from the standpoint of this issue, it's just really a number of FTEs. You decided what the name is that goes with them. So.
Correct. Yep.
Okay.
They're corrections officers. You know, at the time, the board thought this was the appropriate way to fund them. And maybe the board feels differently now, but they're part of our minimum staffing. So if they weren't funded through the mental health tax, they would have to be picked up by the general fund.
So these positions came out of a plan, 2018 or so plan or a
Right, we had identified in the increasing problem with higher acuity mental health problems combined with drugs. I mean, they're co-occurring for most of the people. Very often, very seldom are they just mentally ill.
Correct.
But it's always because they self-medicate when they're out on their own, and that gets them trapped.
Sure.
The question, so that was in response, and the use. One of the things that we had discovered, you may recall yesterday, we heard testimony that the original tax was designed to be split 3 ways. And 1/3 was to go to the drug court. 1/3 was specifically designated for prevention and youth intervention. And then the other 1/3 was for the uninsured who didn't have access to medical treatment of any kind. But by the time we implemented it, the ACA had been adopted. So that ended up being eliminated. And then we looked for what are some of the other things that we can utilize the money for, and making the jails a little bit safer, getting trained personnel that can de-escalate people with mental crises. At least that's the thinking that we're going for.
Yes, that's correct.
So I did have a question. I don't want to cut you off though, Chair. If you have the question.
Go ahead.
The nature of the clients, guests, wherever, the folks that you work with, you're not putting them and seeing them through a course of treatment. You don't see them that long, do you? Most of the people are there just short-term, awaiting trial or bond or whatever. So you need the instantaneous de-escalation.
Just looking, our average length of stay in 2022 was 17 days, which is a bit longer. In previous years, for many years, it was 12 or 13, but 17. And I think that was attributed to the court slowdown and everything that kind of went along with COVID. So 17 days is currently where we're sitting.
So what I'm getting at is the medical health officer isn't designed to cure the mental illness that they have.
No.
Just to try to reduce the risk to other. Yeah. The time's just, you don't have it that long.
Right.
And that's always one of the struggles, because we want to know how effective are the funds? And what are the results that we can use to measure that you're being successful? And I don't know, we've never seen those kind of standards, have we?
This whole thing is so entangled, it's often hard for me to figure out what is correct. When I sat in on Dr. Elliott speaking, thank you for the recollection of the name, he was very, very positive, almost in a braggadocio way, that if with 5 days he could clean up all substance abuse. Now we have 17 days. And so the question might be asked, and I don't know what the answer is, but is that something we should be doing? Because I think currently right now we just try and maintain, right? And there's civil rights issues galore in all this. And boy, I don't want to tackle any of those.
So one of the ideas that we have tossed around is utilizing the youth services vacant area, or more of a concentrated emphasis on mental health treatment. That's where you'd have the folks who are here with us for a long time that you can zero in on a treatment program, because they're separated and they've got their own, almost like a hospital ward. They're a residential treatment center.
Yeah, I'm trying.
But that's a whole different program.
I'm trying to separate out the only way. I'm an engineer by profession. The only way you solve or debug a system is by trying to isolate the component. So the reason I asked about specific mental health, absent anything else, is there clearly are people who are psychopaths. I've met a couple, and you know it. A normal human being on the hair in the back of their neck will stand up. I've met 2 around here, I think. And those, I would want us to have serious commitment to Western states or something like that, which is totally clogged, right? So then what do we do with the other people who are, well, like surprised me in high school. I didn't know what I was doing. I was drunk. Well, to me, that's never an excuse. Just don't drink. And of course, there's some complications here, but I would rather know what the population is we're dealing with and what some solutions are for them. If we're going to have any success, and I don't know how to measure success. It's in this case, because some of those people, you're right, you can't force them. But in return, they force us. We take from a subset of the population, which is like 99% of the people, and we make them pay for 1 or 2% who are totally recalcitrant and say, I don't give a damn what you do, you take care of me.
Right. In the next section that I put in this document, I talk about a little bit about, unfortunately, what success looks like for us is not getting sued. So,
Right.
and it's harm reduction, it's risk management, and that is a lot of how we've landed here with these positions and how we've landed here with the other buckets of funding we're going to talk about today. The back page on this document is kind of a drill down on what the mental health officers do. And I'm going to let Officer Treichel talk a little bit about how he measures success and how he helps our toughest clients.
He just counts the number of black and blue spots he has on him and say, oh, I'm down to 4 today. This is good.
When Commissioner Morton said he's met 2 psychopaths, I swear he looked down this way.
Present company
So
excluded, right?
if you saw me chuckle online, that's my thought. When
To speak to your concern about how long they're there and maybe not having the ability to work with them and get them to a place where they're better. I agree. The problem is that we don't have control over that. So what we do have control over is while we're there, we try to make relationship with these people and then help them to come to their own conclusion that, yeah, they should be on their medication. For instance, I have a gentleman right now who's in custody and who's waiting for a bed up at Western State, which is clogged up. And when he first came into us, he was completely unmedicated. He was out of his mind, to just put it mildly, screaming, yelling, throwing, cussing. Yes, sir.
So he's SUD or what I would call pure MH.
Yes, he's both. He's has mental health, primarily, I would say, and this is only from a layperson, I'm not a doctor, but primarily it's mental health. And then when he gets into the drugs, those mental health issues are compounded exponentially. Like if I were to take drugs, I would be crazy. But if he were to take drugs, he becomes 3 times or 4 times as crazy, if you will, to
Right,
use lay
right.
terms.
Again, I would say for my purposes, trying to get a distinct separation between the two is useful. Because you're not going to be able to do something about my hearing aids, but I will shortly. Okay, anyhow, continue. I'm sorry.
So my one of the ways that I measure success is, are they better than when they first got there? And that's sometimes a very small success. But every little success is its own. You know, we build on that. So the first day, it may not be good. The second day, it may not be good. It may take a week to the point where they even will speak to us or talk to us. And so with having the same officers there, we're able to create rapport with these people. We're able to talk to them and get them talking to us, in which case we're able to sometimes talk them into actually taking the medication that will assist them.
I'm going to be kind of a pain here. When you say the same officer, I don't think that's at the stake. That's your boss's allocation under your advisement, I'm sure. So I don't care whether it's the same officer or not. If you think the same officer is important, then you do it. So I really want to make it partitioned so we know. Like your boss said, her primary focus at the moment is to protect the county from a lawsuit. Check. I think that's an excellent answer. Yours may be different. It's at a lower level, and that's what you're addressing here, I think.
For sure, yeah. Did you have a question about that?
No, I just wanted us to stay on track to make sure we understand the problem. We're not challenging the allocation of anything. We're trying to understand the use of the mental health tax, and we, in the past, some of that was, it's hard to know we've been effective because the situation is we've collected the tax and we're no better off today than we were some time ago as a society. Is one individual more successful now than before? Probably. Does that justify the program? I don't know. That's something
Right,
we're forced basically to decide.
right, you have to ask that question, absolutely.
Yeah, okay.
But when, I keep going back to 2018, but I'm trying to get a picture of what it looked like before then and what it looked like compared to now. And what kind of, I mean, I can get that the fact that the state has closed down facilities and they don't take people and put that pressure on the counties. And I'm not quite sure when that all started, but I'm making a little bit of assumption here that that kind of started and then the county got together and said, hey, we have these pressures. We think we need staff just for this purpose.
I would say it was a slow march in our industry. So I started at the jail in 2008. By 2000 and maybe 14 or 15, you started to see real signs that the population we were dealing with were way sicker and in mental illness in a way we had not previously seen. So we had some bad outcomes. We had some inmate deaths that resulted in some long-term litigation and a number of other things. So like it or not, jails stopped being just jails and needed to change the way we were doing things in order to take care of people safely and have them go in our doors and out our doors. So some of that was not necessarily attributed to anything closing. And I don't know societally why necessarily, whether it was meth, I don't know why, and it doesn't really matter. We're the end of the line and we were just forced to change the way we do business. And so for years and years, having rotating officers dealing with inmates and not having to designate anybody to do this specific work worked and we were doing fine, but that changed and we had to change the way we do business. And at the time, the county was going through a strategic plan process, and the increase in mentally ill, I don't know if it was specifically inmates, and Dennis may know it was inmates or just increase in mentally ill, but it was identified as one of the big goals in the strategic plan. And at the time, the board thought the funding of these positions made sense. So, I mean, to Arn's point, you're right, it is the way we assign things, and maybe this board doesn't think this is the right way to fund it, but they're part of our infrastructure at this point. So it's either mental health tax funding or will have to be general fund.
Right.
So
Yeah. So
Agreed.
we did suffer some lawsuits and stuff
Yes.
prior.
yes,
And since then, I think you mentioned here, we've had one death or
we had one death at the end of 2016. We had 4 deaths somewhat close together between 13 and 14. We had one in custody death at the end of 16, and that was litigated and resolved. And we had a death last year in July of 22 that we've talked about.
yeah,
Yeah.
okay.
But we have not had any inmate death litigation since we've made these changes. So.
That helps me. I'm sitting here thinking, well, I can see the need.
Mhm.
Your question is the same that I have.
Yep.
Should we just be, these positions we just fund and not subject to going away, or how do we do that? Yeah.
Right. I firmly believe it has had a positive impact on our operations, a positive impact on our outcomes.
I suspect it's got positive impact downstream also. by you staying with a constant officer.
Right.
Because you make a little bit of headway that you can hand off to other agencies, if you will. Part of my focus is we've got 6 pages worth of welfare systems around the county, and we don't want to alloy the jail and make it be yet another welfare system.
Right.
Just gets very complicated to analyze, and
Agreed.
Do they wind up in the jail because there's not another facility that could better handle it? And
Well, that's a good-
that's what we have.
that's a good question. It's
And maybe that's somewhat opinion, but
the police officer grabs somebody and brings them to jail for whatever the reason, right?
Well, I mean, you see how people are behaving in the community sometimes. They have to volunteer to go places. So unless they meet an ITA criteria, a danger to themselves or others, or gravely disabled in the community, and unless they want to go to the hospital or want to go to help, they don't have to. So at some point, their behavior maybe continues to escalate, and then they end up in jail because they don't voluntarily want to go to the hospital. They don't voluntarily want to go to treatment. They don't voluntarily want to do anything. So they will involuntarily be brought into our custody and go through our
if
process.
they don't,
Well, they've heard they get three meals a day, excellent quality.
I've never heard that. 3 meals, yeah. Excellent quality, aren't I? Not.
and then once they get to you, they decided they didn't want to do these other things. Let's just say they decided they didn't want to do these other things. It escalates and they get to you. Is there a point where they kind of come to their senses and say, maybe I do need help? And then how do we move them to another? If we had another facility,
Once they get to us, they have to go through the judicial process.
so
So-
then they're,
They may
then
decide,
they're in the.
they may decide that, and that does happen sometimes. Not frequently. I wouldn't say it happens frequently, but they have to go through the judicial process, and we have to kind of just walk with them to do the best we can with them until they are done with the court system. But that's a lot of what these officers do as far as keeping track of their court dates, going to court with them, talking to attorneys, talking to family, because often these are people that would fall through the cracks in the system and end up staying in jail longer or deteriorating further.
Yeah,
How many people in the last 12 months have been grabbed by your organization and submitted to involuntary treatment?
Say that again. Do
How many ITAs have you
Oh.
had in the past 12 months?
you want to take a shot with that, Joel? I'll turn the mic. Guessing?
I couldn't guess on that. It's difficult to know because we sometimes will call to have somebody evaluated for ITA that doesn't meet that criteria. So just because a call to somebody is made doesn't necessarily mean that even
Well,
that person would be taken. So it's difficult to know.
You're not able to designate that, but it
No.
goes through a DCR and a judicial
I
process.
mean,
of
we
sorts.
make a determination at the time, like, okay, we should probably call
Right.
somebody about this gentleman or lady.
So,
Yes.
and just off the top of your head, you figure,
I'll say this, there's at least 2 or 3 a week.
okay, plenty.
And possibly more than that. It really, yeah, sometimes in a day. So it can fluctuate, but generally,
So they essentially get adjudicated, end up being the judge says you will. Where do they go then? To a hospital is a hospital jail?
so if they're adjudicated and finished guilty or innocent.
Right.
And then now they are leaving, we would call and have a DCR come and speak to them. If they met the criteria, then that DCR would call the local hospital. We would call AMR or somebody to come and take them via ambulance to the hospital at that point locally.
So if you had one this afternoon, would they go to St. John's?
Yes.
So we have an adjunct jail in some sense at St. John's.
St. John's has more beds, but we have an unusual amount of psych beds. So not every community has a St. John's. It
Yeah.
has that level of psych provider, so that ITAs are able to go to St. John's. That isn't true in every community.
How much capacity? How much capacity do we have, or just percentage wise, we use half, 2/3 of St. John's capacity?
I don't know their capacity.
But you've never been refused at St. John's.
They meet an ITA criteria, St. John's is not a choice. They have to find a bed for them. Sometimes those beds will end up in the emergency room.
Okay.
So they
You've also talked about the waiting list, though, to get into Western, and that continues. So the waiting list is for the folks at St. John's or for the folks that are,
I could speak to that.
okay.
So the process when you go to court is, do you know what's happening in court? If the attorney doesn't believe that you know what's happening, then he's going to put in a request for an evaluation. A doctor will come from DSHS within a week or so, evaluate you and say, okay, yes, you are, or you're not. If you're not found competent and the judge and prosecutor agree with that, then you're ordered to Western State Hospital. The law is that they have 2 weeks to come in and have that person up at Western State Hospital. As we know, it's right now about 5 months. Earlier this year and last year, it was around 11 months. So it's getting a little better. But 5 months is still far, far outside 2 weeks.
I'm not going to ask you how it got dropped to 5 months. I might find them out on the
I
street corner.
couldn't
huh?
even begin to guess.
So where are they then while they're waiting?
They're in custody.
Yeah.
They're in my unit. They're in, they're here. They're here in our jail, waiting. And that's the time where we try to influence and to, because then we have longer than that 17 days, right? If it's a felony, then that's the process for that. Misdemeanors generally are different in that they aren't legally required to be made competent. And so the cities won't pay for that. And so they will be dismissed generally, and they will just go back out onto the street.
So, and they have to stay with you because they started in the judicial process?
So once you're found not competent, everything else stops. Everything. The only things that will happen judicially is a review, basically to see whether or not you're still waiting for that bed at Western State or if you've gone there. And that's nothing else is happening at all judicially. You are
Okay.
just waiting for that date to come for them to be made competent and then come back. And then once they are made competent and the court agrees, then they, at the point that they stopped, restart then their court proceedings. So it's literally like they push pause on everything until the competency is determined.
And Western State is the only option? I mean, if the
There are others, but
if the genie with the magic
functionally-
thing dropped
functionally it's Western
was
State.
honest and we had a facility, they could go
for-
there, or they have to go to where the state says?
They have to go to where the state says.
It's Eastern State Hospital, but it's in the same boat. So we're competing with, King County, Pierce County, Thurston, everybody on this side.
I think what the chairman might be hinting at is if all of a sudden the county were endowed with $100 million and we built a facility, could you transfer them to that facility for longer term care?
Legislative.
Yeah, so the way I understand it is that it is the responsibility of DSHS to do that. And they are the only ones that are allowed to.
That's the question.
That's what I believe to be true.
I believe there's a push, though, happening to bring some of that back to the communities, which isn't great, and I'm sure it won't come with the appropriate amount of funding. But because of the backup at Western, they're looking at pushing treatment back to be done locally. I don't know exactly how that will look. I think there was a bill last time that didn't pass, but I think it'll come back.
Yeah.
I mean, there's plus and minus to that. A county of our size doesn't have the infrastructure. I mean, you have to have some really high level doctors that we don't have available. It would be interesting. I think
I'm
we have to
sure we
partner
would
with
be
them.
supportive of an appropriate facility being located in Clark County, which is where there's more of a population center.
Right.
I mean,
Right.
would make more sense to have it locally. That's why, Western is in the Puget Sound area, Eastern is close
Yeah.
to Spokane. I mean, there should be one down in Southwest Washington. That
Mhm.
would help all of us out jail wise. In the meantime, we keep paying for the housing, don't we?
Yes.
I
Well-
don't recall, the NAFCare, can you tell me a little bit about the NAFCare contract? Sort of a very,
Sure. The next two, do we want to move on to the mental health expansion piece? That's the next
sure.
document. Okay.
yeah.
So the mental health expansion was approved by the board in 2018. Dennis well, I think maybe you both were around for that.
We both
So
were around
how,
then.
how we ended up there is at the time, we went out to bid in 2016. We had WellPath as our medical provider. We went out to bid, we issued an RFP, and we got one bid from WellPath, no other bidders. And that bid came with a significant increase in staffing and a significant increase in the total cost. So at the time, yep,
As it ties to the mental health tax, did we use that at all for that?
that's where I'm headed.
Oh, sorry.
So the funding structure, we were looking at how to deal with that impact on the general fund. And at the time I worked with, I'm not sure who was in charge at the time, Claire, I think Claire was still around at that time. To look at, is there a way to shift that funding out of the general fund? At the time, I'm not sure the county was sitting on the reserves they are sitting on now. So we identified the amount of staffing that was attributable to mental health and substance abuse through the staffing that WellPath provided at the time. And then that was approved to be funded through mental health tax. So that was a portion of the booking nurse as part of their intake, doing the mental health and substance abuse assessments, as well as the staff time. There's a mental health counselor funded through that and some psych provider time. And if you go to the back page of this, it shows the staffing matrix as to what was attributed to mental health and substance abuse.
And maybe I could ask.
Sure. Dina
Dina?
Crowley.
Hi, of all the effort, I think mental health tax or any other thing is a contract with the people that say we are willing, or we do pay this amount of money for use in this manner. How much of your effort is something that is rationally and reasonably justifiable to a mental health issue?
And you want purely mental health without the SUD, that portion of it, correct?
If you can split it that way, that doesn't mean it should be. It just helps me think about it. But so it's primarily the bucket mental health SUD, as opposed to I'm in there because I misbehaved and now I have a toothache or whatever it is that you have to deal with.
I would say the majority of the patients that we administer medications to, we give care to, have some sort of.
Can you
mental health
put that
concern.
closer to your?
I would say that primarily the majority of the patients that we see have mental health concerns. It would boil down to a history of mental health issues, a history of acting out behaviorally because of mental health. We see a lot of substance use as well, but the majority of the patients that we see have a mental health concern.
So for us, that's kind of what I would call, and I'm speaking out, a legitimate use of mental health tax dollars.
Yeah.
So one of the things that we have to be careful about, and that's the terms that we use. The tax that we implemented is a behavioral health tax. It provides programs for both treating mental illness as well as SUD. Okay, but the county early on just started calling it just the mental health tax, and we forget that. It's for both of those types of programs. My understanding is that for folks who have serious mental illnesses, they've been to doctors, they know they should be under prescription drugs, but it's incredibly complicated to get those drugs because you start feeling better, you stop taking them. And then you lose contact with reality. And we have so many roadblocks for legitimately getting those very powerful psychotropic drugs that they turn to the petty crime to come up with the cash for the cheaper drugs that make them feel better right away, regardless of the long-term consequences. And so what they get picked up for are the petty crimes that they're involved in order to sustain the drug habit, to make the voices go away, or the bad feelings, or the depressions. And it gets to be this horrible vicious circle. What we do know is the county pays one way or the other, because they end up here if we don't have some kind of treatment program that addresses both. And there's not enough money. And the state doesn't do their role because there's not enough place for the really serious cases where they've lost touch with reality and they're a danger to themselves and others. But until there's room for them, we house them. And there are times when they're mixed with the regular population because they're at the jail. And that's where you need the special trained officers to make sure you can't just use thump therapy like you might with people who are just misbehaving. And that's kind of a crude look, and I shouldn't use those terms, but the mental illness needs different type of approaches. And that's so frustrating because it's all expensive.
Quick question for you. I believe the maximum we could impose 0.1%. Are we allowed to do 0.05%?
I think it's just the 0.1%.
It's either up or down on that
Yeah.
one.
This is probably kind of I'm asking you to speculate a little bit, and maybe not a fair question, but we hear the gamut from quit doing it, the system's broke, it doesn't do anything, to no, I think you should still do this. It's just not being used the right way. And so this is a little bit of a loaded question, I guess, is if you were to look at it and you didn't have the mandates and everything else, and I don't know would you say the system is broken, and what would an unbroken system look like if you weren't told what you had to do? That might be tough to answer.
I'll try. I would still want to treat people the way we treat people, and I would still want to keep these people safe. So I think I would want, if it were my child in a jail, I would want my child to receive adequate treatment. I would want my child to receive mental health services, and I would want my child to be safe. And I think that's the standard we should use.
Do you have enough choices now when they're in jail? Because it sounds like once the process starts, that you don't have a whole lot of choices.
As far as when they get out of jail.
Yeah.
No, yeah, you're correct. So I believe we have a responsibility to do our very best to keep people safe while we do have them, whether that's one day or 2 years. And we have people that have been with us for 2 years.
Yeah.
So I provided some case law. I mean, there's no RCW that says we have to provide medical care, but there's plenty of case law that shows what happens when you don't. And so unfortunately, case law is a lot of how we end up doing the things we do in jails or in prisons as well. But that's the reality.
One of the other huge changes that I've noticed just in the 10 years that I've been a commissioner is the state has poured resources into mental health treatment.
Do you mean in prisons or just?
So through the BHO system.
Oh, great. Yes.
Yeah.
Yes.
So these are not for corrections, but for
Right.
people who are, eligible for Medicaid. I
Mhm.
mean, there's a lot more resources that are available. So for everyone that comes into the jail system that we're able to convince to begin treatment, the hope and expectation is they'll reconnect with those treatments once they're out on their own.
Mhm.
That transition is extremely tenuous, is very difficult. There's a question of housing, because if you go back to the same environment that kind of encouraged you to do the bad stuff, you may make bad choices. So it's so complex. It's so complex. But that is something that is better than it was a decade ago. That BHO program, the Medicaid program being expanded to emphasize the behavioral health treatment.
Right.
But again, the challenge is you can't force them. I mean, you try to force them into treatment, it's not going to work.
I don't know that I agree with you, but I do agree with Marin. She's at the end of the line. She doesn't make any of those decisions. There's nothing to do with them. And, but she has to survive, live, and try not to get sued.
Try not to get the county sued.
Yeah.
And the other
She's,
piece, oh,
she's kind of at the point where, you think if a person really wants to change, they'll find a way. If they don't, they'll find the excuse. You dealing with the excuses.
Right.
They end up in your jail.
and the BHO funding is great and it's provided a lot of layers in the community. None of that touches the jail. I mean, for the most
Right.
part, because none of it's billable
That's right.
if, once they're incarcerated. So there's all these, great wraparound programs in the community, but they don't start until the person gets out of jail. And
Again,
so,
Medicaid is for those without resources. If
Right.
you're a guest of the county
Right.
county has resources. So yeah, it's on our hook. So how do you not only harm reduction, but kind of cost reduction? And
Correct.
how to do it efficiently. And
Mhm.
it is complicated.
we provided some statistics at the bottom of that, the page on the mental health expansion. And if there are any questions around that, Dina can answer those. Talking about what those bodies do, what the NAF care positions that are funded by this are doing.
And these numbers are for the folks that aren't waiting for space at Western, right? These are the other inmates, or are you including
them.
those as well? It's all of them.
All of them.
Okay.
Just a comment, waxing a little bit on what you said, Dennis. One of the reasons I might be disagreeing, or there may be a couple, certainly we constantly connote dollars with tackling the problem, and maybe it's dollars that promote the problem. People do weird things when they're in Hollywood and they have a lot of money. So it's not just a dollar issue. The other thing is I've talked to plenty of addicts, and drugs are attractive to them, just like an alcoholic knows I'm always going to be an alcoholic. I just have to stay away. Well, goes back to your housing issue in the community. When drugs are as available as there are, is no wonder we have an issue. The people I've talked to have actually gone through formal detox and all that kind of stuff for 4 or 5 times before finally they said, this is too dang painful. I'm not going to do it again. So
I would say 4 to 5 times those were some easy breezy friends of yours. We see people that are coming in 20 times in a year detoxing, that 4 to 5 times does not cut it for most of who we're dealing with. That detox, they forget that detox as soon as they're done with detox, and
well, as a
move
chairman
on out the
said,
door
you
and
get to
restart.
view, you get to view the problem ones.
Yeah.
which is unfortunate and actually really pretty
Yeah.
sad to see, but that's the reality of the people we're dealing with.
So another little bit of history, I think, at least from what I remember, we were going through some budget struggles in 15, 16, 17. right around
2008
those-
until 16.
And
Yeah.
corrections made an offer to reduce staff to help the county get through all that. And this has been one of the strategies we've used to try to bring back staff to
Right.
to address the mental health problems, but as well as, we're not dependent on the general fund because it was not growing that fast.
Right, from
Up
two
until
2008 to
about- Up until around the time we got. the
Right.
landfill built.
2008, when I was promoted to director, then we started facing some tough times. I believe we cut maybe close to 30 positions in the corrections department.
That was,
I
yeah. that
believe there were
was-
12 officers we ended up.
But just since
reducing,
I've been
and
here,
it
I
had
know
to
there
be-
was at one time, I think
Yeah,
you dropped
just kept-
5.
yeah,
Something like
yep.
that.
Yeah, and so we've added, the two officers that we talked about previously were ones that were added back.
Yeah.
I
Yeah.
believe I think we've only added back 4 and we reduced 2 of those during COVID, but I may be back to ask for those in coming years.
That gets to that one other thing is if we don't have this 0.1%, what happens? Comes out of the request is coming out of the general fund.
Right.
So,
And I mean, unfortunately, these things were done when the county, well, I mean, I don't know about unfortunately, these things were done when the county was in a different financial position. And so there was, some interest in looking at creative ways to fund things we ended up having to do. I mean, it's appropriate funding. It is for that, for these purposes that are appropriate to the behavioral health tax. But partly we landed there because of the financial situation the county was in.
Yeah, it's up to us to look at priorities because the sales tax is great when sales are good.
Right.
And you press that to the limit and sales go bad and you've got a problem, right? So property tax is a more stable
Yeah.
source of revenue.
Yeah, the threat to sales tax revenue occurs when we have deflation. When the prices go down, that's when the revenue gets hit. Otherwise, it's as long as you have inflation, the prices continue going up.
Or as long as a free printing press in DC stops.
So I mean, so the report from the state economist released yesterday was the state's going to have $336 million more for the rest of this biennium than they expected. Of course, they said it was due to the new tax on capital gains.
The way I would say it is the people will be out about 330 billion
Yeah.
and they are better, more intelligent spenders of their money.
Yep. We can-
All right.
On that.
Oh, there was one other question I want to ask. The initials that come from, or an acronym, ITA has been downgraded a little bit. It has added another option, which is a downgraded ITA, OAT, OTA, ATO, it's one of those. AOT, thank you. I have to remember that. I keep forgetting it. Has that impacted you any?
I'm not even sure I'm aware of what it is, so no. Oh. It hasn't trickled its way to us yet, so
Okay, yeah,
if it's an option, if it's gonna help us, I'm very interested. but,
well,
I need more information.
instead of sending them to St. John's, does that mean they go back to you now and they're occupying another space?
I'm not sure. I would need some
No,
more
I think
information on
they're
that
on their
program.
own
I don't have.
recognizance, aren't they?
Yeah.
They're on their own recognizance? Under. Yeah, we probably should ask you to come up front and repeat that because we have the public that.
This one. I'm Trish Rodman, Northwest Medical Advocacy. And I've been in the behavioral health field, not as a clinician, but just working on policies, contracting, credentialing since 98. And
Did you say your name was Trish?
Trisha,
Trisha?
sorry.
So
Rodman.
just make sure we can hear the reverberation. If you look at them to talk to them,
And I can't.
it doesn't get
Okay.
across there.
Okay,
So
do you want me
Yeah,
to repeat?
but you're not required to identify anything, only as you choose.
Okay. So, AOT, there's a lot of, like Dennis was saying, there's many services for the Medicaid population. So assertive outpatient treatment, we have the mental health court, we have FACT. We, a lot of resources, but I believe that's once you're outside of jail. Or when you're done with your ITA, if you're inpatient. Questions I do have regarding the mental health tax and the use for the mental health officers are, what training do they receive to deal with the mental health population? And are they licensed through the Department of Health at all? Other questions I have would be for WellPath, what, did you say, I know I'm not supposed to look, did you say that WellPath is still the current medical provider? No, it's someone new.
Correct. It's
Okay.
NAFCare,
What was it?
NAFCare,
NAFCare.
NAPH.
Thank you.
Mhm.
So, you have an RN, you have a medical director. Do they meet the criteria for a mental health professional or a substance use disorder professional? Is the medical director board certified psychiatrist? I think those are things that we really need to start looking at. I know your hands are tied, Marin's hands are tied, but I was here last week, there's not communication. There's no communication really between providers. And if somebody is sitting in jail who has received prior treatment and was stabilized, especially if they were on an LRA and agencies dropped the ball and didn't follow the court order, and now this person decompensated. So are we obtaining the medical records or information from the prior companies or organizations when they were stable so they can be put on the same medication?
How does that work?
That was a lot of questions.
I'll do my best to address it all. So we do have registered nursing staff there.
Don't forget to get.
We do have registered nursing staff that administer the medications, but we also have a psych provider that's there that continues medications, meets with the patients that have a history of mental health illness and were on previous medications. We try to stabilize them while we have them there at the facility. We have a medical director that reviews everything and also tries to track down records. Some of these patients aren't in a position to give us their history when they come in. So as long as we have consent to try and find it, we do our best to locate any history that they have, any previous medications, what worked, what didn't, any treatments that they've gone through previously, so we can try and coordinate what the best care would be at this time.
Okay.
And I'd like to expound a little bit, bloviate. Licensing is sort of an interesting thing. I think the human-to-human interaction is probably something that is far more important. I know many competent physicians, say from India, that have come here. It takes them forever to get a license because they're foreigners, yet I know they're darn good doctors. And because we have such fancy equipment, doctors become more or less operators of equipment than, look at this person. And my mom was an RN and she knew health without any of this other stuff. And so I think it's a fair enough question to ask from a protection of the jail from a lawsuit question, but I wouldn't impose that requirement on a CO.
And to answer that question, the officers that are assigned to the mental health unit are not licensed counselors. They're corrections officers and have to do all the things that go along with that. We do provide additional training and try to identify training, but they're identified because they're just better at finding that gray area. And it's a very black and white business. So, some officers are better at working with people that have challenges than others. Officer Trikel's very good at it, which is why he's doing it. So really, it's kind of an on-the-job identification of people, of our staff that are really well suited for it. And then we try to bolster up their training as it comes up. But no specific licensure, no. Was that all of your questions? I wasn't sure. Okay.
One thing I would encourage, and I would be in total support of, with using some of the mental health tax money. Well, I think it's necessary to have the officers in the jail to deal with the mental health and SUD. But I'm also in support of sending them to more intense training on dealing with the different diagnoses and suicidal ideation and, and maybe you already do that, Marin, but I'm in full support of that, because the more knowledge you have, the more powerful you can be with intervention. I also think we do need a mental health inpatient and substance use inpatient unit freestanding away from the hospital. I don't know why, and maybe it's because of all the different laws, why we can't bring in local providers into the jail. And I think it's because you can, or I don't know, but to help with medication stabilization or just intensive therapy in the jail. I don't know.
I can tell you that why they won't do it is because they can't bill for it. Because when someone's incarcerated, Medicaid, Medicare, all of that cuts off unless they have private insurance, which is pretty rare for our population. So local providers cannot come see a client in jail and bill for it. And does that make it right? I don't know.
You're
That's facts.
you're accurate. You're totally correct. But if we use some of the monies from the mental health tax to where it would provide someone to go into the jail and meet with these people, not necessarily the medical or anything like that, but for therapeutic reasons, and initiate substance use treatment. I know they do the MAT in the jail, but I don't know about the substance use treatment and going through all the ASAM criteria and whatnot. But that, I think that would be beneficial. So like a grant or a contract or.
Are you thinking about something like having AA and NA meet in the jail for inmates?
No, it would be, so for substance use disorder, there's the ASAM criteria. Specifically, it's the different level of care for people that have an addiction issue. And so the jail starts the MAT, so the medication assisted treatment. And I mean, that can help with the
Okay, so-
detox and withdrawal.
So you think what's going on in the jail is not adequate or can be?
I think it
vastly
can be
improved?
enhanced, but like Marin was saying, local providers will not go. Well, they do lose their insurance for some portion once you are incarcerated and if you're on Medicaid. And so we would need to have a separate pot of money to contract with a group of local people who could go in and start this process, an intensive treatment for our mentally ill. And especially if they're waiting for a competency evaluation. I mean, if, you're able to get them somewhat stable, but then I think that brings up other legal aspects of, can they really consent to talking to somebody, right? That's outside of the jail, but.
I probably have one sort of fundamental objection, which is we want a cure solution, whether the help comes from here or elsewhere. I just want the results, and I want to take the best candidate, even if they might travel up from Clark or travel down from Lewis. So.
No, I agree.
So you think that's an opportunity to utilize these funds then to contract with providers to come in and pick up the gap?
It's certainly worth discussion, but I would look a lot for guidance from the table here. I think they have a lot of understanding and I don't,
Mhm.
so.
Particularly if we have providers who are already providing treatment, but their clients go into jail and then
Yeah.
that payment
It-
stops. Is there a way to keep it going? I doubt they volunteer. Although I think we have one that's trying to figure out some way of maintaining contact.
We have two full-time mental health counselors, one through the county, one through NAFCare, that work master's level counselors that work in the jail with inmates.
Yeah.
The gap with their local providers has existed as long as I can remember.
Sure.
That's a battle we've been fighting a little bit. I think it would be really beneficial for providers to come see inmates while they're in custody to kind of help transition back into the community. But that is a challenge that has never been
Yeah.
met. So
What I'm hearing though, if we had a discussion and said, yeah, we think this is a great idea, we set this pot here for that you're not opposed to it. Or it doesn't create problems for you.
no, I mean, we could end up with some conflict with their attorney booths because the meeting spaces are all the same spaces, but that's
Yeah.
logistics.
That,
Yeah.
that was my only thing. I think of in this day and age, liability issues, you got a civilian in and something happens to them, are we on the,
It would likely be in a non-contact booth,
yeah,
so through glass. So
yeah.
that isn't an issue. The issue is we only have 3 attorney booths. And so when you start having a lot of providers in those, it creates hurdles for the attorneys to see their clients. But that's not something we couldn't get around, I'm sure.
Gotcha.
Okay. So we move on to the medically assisted treatment portion of the funding. I talk a little bit about why there is an RCW that says we need to provide medically assisted treatment. There's also case law that got us there. That was out of Whatcom County. And there's also ADA implications. It's considered a medical disorder, so we're required to treat it. I just want to acknowledge, and I told Dean of this, I think this is too much money for what we're getting. But this is where we're at currently. We're under contract with NAFCare until March 1 of 2025. So we'll likely be going out to bid, or we will go out to bid end of next year, and we'll probably be writing the RFP differently to try to address that. We also applied for and received a state grant to expand this. And we submitted a request to increase that funding, which will reduce the amount we're using for MAT through mental health tax. So we're trying to shift to the state and we'll continue to push for that. But currently we're sitting at a higher dollar amount than seems appropriate for the percentage of inmates that are served. But that's,
The lawsuits, like the $27 million
Mhm.
stuff, that's really impacting a lot of your contract prices, right?
Well, not yet, unfortunately. So I would anticipate Clark County went out to bid for their medical contract last year. I believe NAFCare did not submit a response to that. WellPath, our previous one, did. It was a pretty steep. I think they're at maybe 5.5 million or something around there. So the lawsuits in the state of Washington are directly impacting how we're going to receive our bids. Our bids are going to be higher. They're going to be higher staffed, higher administrative costs because of their liability and insurance and all of those things. So
Yep.
I don't anticipate when we go out to bid next time that we're going to be getting anything lower than what we're currently paying. I would anticipate that we would see an increase because we entered into this contract before some of these really big lawsuits hit that have impacted the medical care.
And we had a
companies.
pretty stiff increase last time. right?
Correct. Mhm.
But that was a result of, that was compounded by a lawsuit also,
Right.
right?
So there, I provided the information on the medically assisted treatment. The funding is identified on the last few pages. And I also talk about on this how we anticipate the funding to be reduced. The grant we are getting through the state will be before the board in the next few weeks. So that will include an increase to that, the increase to the state for the reduction that will in turn reduce the funding to NAFCare that is subject to the mental health tax. So I don't know if there's any questions about functionally what MAT looks like, or if there's an understanding of that, or if you had any questions.
I, my only, my only question really deals with how often we get inmates who are already on MAT and they screw up and get put in jail, as opposed to those you receive who haven't started and should have been on it.
Sure.
And I think you shared that number with us several months ago, but I can't remember what the results were.
Currently, it looks like 3.19% are continuing.
Okay.
So we started 7.73%, 3% were continued. So we're starting more than we are continuing.
Okay.
We also use MAT as part of our detox protocol, which is a safer way to detox. Again, that's harm reduction and helps with county liability. It's a safe way to detox inmates and has become industry standard. So the total number of inmates being administered MAT is, 16.5%. But
So those that are started on MAT in the jail
Mhm.
need to continue, because that's not just a 17-day treatment, it's a long-term treatment. Do we have a system in place to refer them then to a provider so they can continue? Or is it on, they're left to their own devices to
We have.
connect the
sorry.
dots?
We have everything coordinated for their discharge, so that way we get notified when they go to leave. We contact a local provider to try and set up a next day or same day appointment if possible.
Mhm.
Even if they don't get that follow-up immediately, we send them with medication to last until they can be seen by a local provider. Once they're out of our custody, we don't have anything
right.
like that,
Yeah.
but we try to set them up with all the tools and resources needed to get them there.
This is a good time to recall the earlier statement that I think Marin thinks is highly incorrect, that Dr. Elliott, who he's the CEO of NAFCare or
Medical director?
the medical director, says he can take care of any addiction in 5 days and do it safely. I do recall that argument accurately, don't I, Dina?
I wouldn't want to put any words in his mouth or anything, but I
Okay, I
can
could-
say our
I-
detox process.
I tend to recall those things pretty well because I had the devil of a time having to get him to answer a simple question because he wanted to make it be a sales call. And I was really interested in facts, not sales. So 17 days average, I'm just saying, maybe we ought to look at that less so as a continuation. I mean, if we're going to pay extra, maybe less so for a continuation than to send them out there. Has its problems too, but at least clean and on hooked.
sounds like I missed a real good meeting though.
Well, I came to speak to you afterwards and I think I told you I was a little less than happy because all I think we ever want is just, we're not hurdles, we're part of the solution, just tell us everything that's germane and then we can start to probe collectively as opposed to imperiously.
Yep.
It's great what NAFCare is doing and setting them up for success and with enough medication to get to the appointment if they can't get in next day. But who's following them to make sure that they're making it to that appointment and they enter treatment? That's where our gap is. That's where we need case management.
And the challenge is, whose responsibility is that? Once they're no longer in our custody. And that is a challenge. I think society is struggling with that, if people are not going to be responsible for themselves.
Once they leave though, who's responsible to set them up with their insurance, or does their old insurance, if they're Medicaid, enact upon discharge? And if so, if it automatically enacts upon discharge, then why are we not contacting the case manager of their Medicaid? Because United Healthcare, Molina, CHPW, they all have case managers. And and they're paid. So why can't we contact them to make sure to follow them through the process?
I I think you described it early on in your comments. The agencies don't talk to each other. There is no
Oh,
coordination.
it's
I mean,
frustrating.
yeah, it is frustrating.
We
It is
do
stressful.
communicate with them. They get a list of our inmates and they're able to identify their clients that are in custody. And while I understand that maybe it would work better if we chase that around for them,
You
I
have-
don't feel like it's the county's responsibility to reach out to Molina, to make them come in and see clients. They can identify who's in custody that are their clients. And I think that's their role and responsibility and not something the county needs to additionally take on.
Yeah,
So,
I
so one of the things we always look at with the criminal justice system is recidivism. It would be interesting to see if there are any studies that say, if there is a program that fills in the dots, that connects the dot, does that demonstrate a reduced recidivism, which is a net gain, I think, for society. They're not coming right back in because they slip back into the old, again, that's kind of a whole new program that we have to try to invent if we think that's worthwhile. And I don't know if people have done that.
Well, a piece of information I have wanted to get since we've started doing MAT is, did they follow up with the provider? Did they go? But we're not even able to get that because of HIPAA.
Yeah.
So once they leave jail, we don't know what happened. It would, to me, that would be an indicator of, yes, this may be working, but we're not able to get that. So, I mean, that's unfortunate, but
Let's play a numbers game. How many COs do you have?
42. We're staffed with 42 is our,
Okay.
Is what we're
Let me call
budgeted
it
for.
50 is an easy number.
Okay.
Okay. And let me say you have 250 inmates as an easy number. What we're talking about is having a personal allocation of a mom or a dad to each person who is in trouble. We can't afford adding another 150 to 200 COs. But when we let the people out in the street, we were talking about following them along. That's a recipe for disaster. I think you addressed it correctly, saying you really can't be responsible. No, those people who went through the system are responsible. Part of what we suffer is that we continue to make excuses for them. And I don't know what it means not to allow them to do that. Maybe it, but it's a bad system.
Okay. Anything else? This has been, for me, highly informative because this is the first time I've been through this, mental health stuff and how you all utilize it. So I very much appreciate everybody that's come in and helped educate myself on it.
Sure.
Thank you.
Nothing else? All right.
Thank you.
Thank you.
Thank you.
Your gentleman's pleasure. Do you want to take the executive sessions before we get into this interview process or?
Yeah,
They-
let's do
They've been
that.
waiting a while, so.
Yeah, let's
Are
do
you
that.
guys okay with that? Okay, what I have written down here, you tell me if it's different, but I have potential litigation for 15 minutes and contract negotiation for 5. Okay, so let's go ahead. To begin in about 5 minutes, okay. That works.
The board is extending the executive session for a period of 5 minutes until 3:07. The board is extending the executive session for a period of 5 minutes until 3:12. The board is extending the executive session for a period of 5 minutes until 3:23.
Okay, we're back from executive session. No decisions were made. Looks like we have do we have something? Jessica, Kim, you guys got, oh, you're just sitting in? Okay.
So the interview process is on the board's agenda.
Right. Okay.
That's why. Sorry, Jessica Warren, Human Resources. That interview process on the agenda, it's something that Commissioner Mortensen has asked to discuss. So I don't really have anything. I thought it would just be a good opportunity to discuss that with the board.
Yep, go ahead.
Okay, in with a little bit of advertisement, I value our staff and we need to value them. And that value starts at the beginning in the interview process. And I like it to be an even-handed opportunity for both groups to evaluate each other. And both groups are really responsible to make a sale. It's not always it's just maybe my anachronism. It's not always just the dollars and cents. It's, is this the right fit? And that typically is an issue. So the way we look at senior people, well, let me back up even a little bit more. When I first came on board, the interview of lots of things ended up being a form which came from HR, but I don't know whether it originated in HR, but they supplied it. And we filled in the blanks, and the job applications, I think across the board, are orientated toward this job doesn't require lifting more than 50 pounds, or you have to be able to stand on your feet for 12 hours, or stuff like that, which at the deputy director level and the director level, actually, I think would confuse a candidate. I was fortunate to be involved in one senior manager interview, and I would have walked out on the interview in short order after saying, I'm sorry, I believe there's been a mistake. The questions were somewhat ridiculous. It was in a group of people as opposed to individual. And if we're looking for top-notch people, I think we want to address them on an individual basis, a human to human, try to make it the most out of the communication. It would cost us a little more time, because if we get 4 of our senior level people in a room at the same time to interview a candidate, then you save some time. But the cost of that is you end up with an interview that is all over the map. Yes, we each get to see the answer that was done to a question, but at least in my experience, and here's some more advertisement, I've interviewed probably 1,000 people for all kinds of levels. And trying to find the right candidate is a trick that each of us has. It'll be a different kind of thing where you actually want to pursue a train of thought, and you can't do that in the committee approach, or I have a negative term for it, but I won't go into that. So I put together what amounts to the paper you have in front of you that says, let's change this. Let's do individual interviews, and let's do them in one day. So the first, and I think I proposed a 45-minute interview, maybe scheduled hourly. So it would take the candidate, the prospective candidate, half a day to be here. And the interviewers would be, HR has to be there, in my opinion, BOCC member. And again, this applies only to directors and the deputy directors, and one member from another department, because we don't want to be isolated from department to department. Most of our departments exist that have to operate in a complete system. So I would choose a member from another department, and then, of course, the member or members from the hiring department. And the process would be setting up the appointments. That'll be a chore for HR. And when I say chore, I mean it's a chore to get all that stuff together. And then the interview process is terminated at the end of the day, when all the interviewers come together and meet, and maybe sequentially just run through and discuss things, beginning at the top with acceptable or not acceptable. And then if it need be, you start to discuss the qualifications or concerns. And out of that, HR will come out with a responsibility to do the due diligence on the claims in the CV. And from there, ask the hiring director or elected and say, I found this out. Do you want to make an offer or not? Here are the review comments and all that kind of thing. That's essentially it. I would encourage we do a little detail in that in an interview process, still we allow the interviewee to come back to us. And by come back to us, I mean, allow some time. You're done asking your questions, you say, okay, now it's your turn to ask us questions or ask me questions, and you'd proceed like that. I think you get the most out of that. Some people interview very well in a public scenario because they have a gift of gab and some don't. And you really don't want to discourage the quiet super performer. So that's my suggestion. And I'm it's a strong suggestion on my part.
Is it for any time a director or deputy director position is filled? What if do you envision any flexibility if it's somebody that's been working with us for last 5 years or whatnot, and a position comes open? And do we still run them through an interview process, or are we, if we're all comfortable and been working with this person for so long and we want to promote them to this, do we still see the same process?
That's really a good question. You know, I'm not a bureaucratically orientated individual, and I think there's always going to be exceptions where we know this is the right thing. And
Okay.
the important thing for me is the board really has to have the last say, but I also want HR to have almost a veto power on that, because there are things HR can see that we might not. I know I relied very heavily on HR in the past.
Well, and probably stuff that they can't even really relate.
I beg your pardon?
Probably stuff that they would not be able to relay to us at times too.
Could be, yeah.
Could be.
Yeah, there's some times where you just have to say, no, I'm going to call the chip in on this one. No.
If we're talking about a real strong guideline, we want to see this, but we have some flexibility for people that we're already working with and within in the deal. I mean,
I think it's important that we all know the individual before we go too far along the process.
Yeah.
And then it does change the nature of, we might need a separate job application. I don't know the only applications I've seen look like they are for a union position in a shop someplace and.
Right, so we utilize NeoGov for our applications and it's most government entities use NeoGov. It's a standard application process and then you can have them submit resumes, cover letters, sometimes writing samples. So there's the ability to change those when you're
Yeah,
doing this.
I'd like to change that because we're College County. We're not everybody else.
Mhm.
We want the best individual treatment. We want to stand out as, like the Board of County Commissioners has stood up for that's been very noticed for our intent to allow people to speak. We want to have a reputation that maybe we don't pay the best, but we're the best place to be.
Mhm.
And you can't do that if you follow standard block forms.
I mean, I personally like having the online application process. It makes it easier to manage, at any given time, we might have 20 different job applications or job postings going on with, numerous applicants coming through.
Yeah, what I'm suggesting here, I don't know how you implement it. You may have to fall back on exactly what you say. But I do want to make a distinction between your senior level people. And if that works out well, maybe your senior level people want to apply that same approach going down on the staff, going down the line of people reporting to them. I have no pretense or desire to say that your applications cannot come through an interface in the web there. I would say for a posting of a senior level position like that, I would have as opposed to being like every other one, I'd maybe highlight it and say, please send your CV to,
Mhm.
and consider that the application. You're going to have to find, you're going to have them fill out a sort of some of their personal details, and I accept that they will need to fill that out in a form, and that should be sort of a generic.
Understood. And then with the distinction between internal applicants, I think,
I'm sorry, I can't hear you.
oh, sorry, with the distinction between internal versus external applicants, there's been numerous positions, especially for the deputy director position, where the person is appointed, so there isn't an online posting. It's an appointment to deputy director, so there's no online posting. It doesn't go externally. It doesn't go through that process.
Yeah, I think that would fall into the chairman's question. I do think, and I'm a little bit pedantic here. We can only do our function as long as the department heads or the directors do their job and view us as part of the solution as opposed to anything else. And I would recommend that each of us get involved with that, say, an internal candidate, that we actually speak to each of them.
Mhm.
We can't do that with electeds as well, but that's an issue beyond the scope of the moment.
am reading through this and I'm trying to discern why you want us to interview the deputy director. Can you envision a time when we would force a director to work with a deputy director they don't want? Or would the
No.
director still have veto power?
Correct. It's the latter. You never, in my book, never say never, but do not force. Use of force doesn't accomplish anything.
Mhm.
So if a director wants this deputy director, and we don't think it's the right choice, we can veto it. In the same way, if we want some, they can veto it also, to the point where it becomes ridiculous. And I think we the board still has a responsibility for the staff, and they're the ones that should authorize the making of the offer.
So you want to reserve the power to veto the director's creation of a department that they are running,
Correct.
and that's improves management?
I beg your pardon?
That improves management?
It does. You might ask, does it improve management when you already have a working system? It becomes a moot point. Does it? When I first came on board, I thought several of the directors weren't very good. And why would you want somebody to choose employees for you when you don't think they're to have the proper attitude? It just doesn't make
So the
sense.
important thing is if there is a director who has lost our confidence, get rid of them.
Well-
They've got to go, and that's, so I'm just trying, I want to make sure that if we hire a director, they actually are in charge. Because I'd hate for all of a sudden the deputy director to end up feeling they've got more power than the director, and then you've got
Well-
management rivalries that aren't.
Well,
appropriate.
if you're swayed by that, that's on you, but there are three of us, and I've said, and I'll say it again, I am glad that there are three of us, not just a single individual making these kinds of decisions. So it's a board level decision requires the two votes, and hopefully that answers a lot of your questions.
Which I absolutely agree that for the directors, absolutely. I mean, we have to have confidence in those directors, but I'm just wondering when you get down to second guessing the directors on who their deputies are, that just doesn't that send the wrong message? We don't have faith in the director. They're not smart enough to pick the right deputy.
If-
And I don't know,
If that
I'm
sends-
not that familiar with,
Yeah,
with,
if that sends that message to them, then maybe if they feel that, maybe then that's what they should feel. I always crave to get input from the knowledgeable and responsible individuals. People are probably annoyed at my asking them a lot of questions about, what do you think about this? What do you think about that? There's nothing bad there. This would not prevent a good director from doing good things. It might prevent a bad director from doing bad things.
I understand.
I have not operated under something this specific, but I will say, before I brought anybody into department or into a level that I was, say I was hiring a new VP, I always gave the other two VPs the opportunity to cancel my decision, because it was important to me that they all kind of fit together. And I even did it when it was down below that, when I was running the mortgage area. I'd bring somebody new in. The other employees had the right to veto me, because to me, it was just it was just easier. I always had a boss that he told me, and it's not a great analogy, but if you have a whole pie and you have one slice that's bad, it contaminates the rest. It doesn't get better. So I always tried to identify that bad slice up front if they weren't going to work right with the people. And sometimes my staff knew better about that than I did. Then I gave them the power to veto me.
Yeah,
And
to
do
be,
that.
to be frank, I looked at HR in the environment I was in as typically it was a lady in HR, and I had a lot of confidence in them, but there's a factor that most of the engineers, not all of them, but a large fraction of them were males at the time, and they can be confused. And they weren't necessarily very good at assessing personalities, and they certainly were not very good at assessing the response that women have towards men. I'm not sure quite how to say that. In other words, some men creep the ladies out. Being really blunt, and I can't detect that or be sure. That's why with HR, we had enough confidence there that I'd say, so is this going to be something? And they didn't have to say much. If they thought they were going to get creeped out, I would say, let's pass, let's find someone else. It's just so much harder to undo a mistake.
Well, my take is, or I'm really never, I'm okay trying stuff. I just want to know that there's flexibility in here as we talked about versus somebody that's been here a while. We have a good sense of them versus outside. Instead of, if we're comfortable, we can make a decision not to run them through this whole process.
The only caution I can give you there is that vision that comes from an interloper. I'm not from around here. And I looked at some of the things I've seen done and they weren't done properly. Is it choosing a personnel? Sometimes, yes. And does that say no to what you said? No, I already answered that and said, yeah, there's flexibility there. We could all three of us decide this is a go. Then HR would probably have to chime in and say, yes or no.
Yeah.
Although I would imagine HR would have done the vetting beforehand. It wouldn't even propose as you narrow the list down to the top 4 or 5 or whatever we decide on.
Let me tell you a story about that. Yes, but HR it costs a lot of resources sometimes to do due diligence. And if there are 5 applicants, that's 5 times the effort for applicants, maybe 3 of whom we would say, you know, that's not going to fit here. And then there are just rules specific more to what the chairman said. We had a requirement for senior engineer we had a requirement for a candidate who had a PhD to come in at least a senior engineer level. I had to fight with HR to bring a PhD guy in at associate engineer level, 2 steps down, because HR policy said, no, you don't do it. They have a PhD. Well, the PhD was not totally relevant to the situation. And I did prevail, and that fellow turned out to be just a fine individual. He was different than a lot of other engineers. This is an example of something we would look for. A lot of engineers are dedicated to the job, almost oftentimes at the exclusion of the family. This guy made it clear to me, I'm an 8 to 5, you'll get my full attention 8 to 5, but then I go home to the family. Like, okay, not a problem, clearly understood. So there's flexibility if we want to apply it. Fidelity to rules, these I would call the guidelines.
Yeah, I'm glad to hear that because that's the way I've always looked at the rules. I respect them, but they're guidelines and there's things that tell you, well, it doesn't make sense in this situation.
Right.
And as long as we're flexible with that, I'm willing to try it. And I don't even know how many director and deputy director
It may
positions do
never
we
be
have.
tried before I'm out of here.
It probably, those opportunities aren't that often, I would guess.
No, not very
I
often
don't know, there's just,
at all.
there has been a turnover in HR though, hasn't there?
There, and so like in my case,
I'm joking.
my deputy director was appointed.
Yeah.
And when I was deputy director, I was also appointed, but I know I went to HR when I wanted to choose to appoint. Sorry, I went to the board.
You asked the board.
Yeah.
Exactly. And I thought that was a reasonable process.
Currently, HR may or may not be involved, it's, the director's discretion on if HR's involved in the process.
And again, we're not really talking about the other elected officials. They're
Correct, yeah.
in charge of the road. They just have to follow.
Specifically the
policies.
directors. Mhm.
Yeah, and in that sense, I would say this is a guideline recommended for the other electeds to follow, but if they don't want to, it's okay.
Yeah, and they don't. I'm very rarely involved in elected officials' hiring processes.
Okay. And we're not putting an undue burden on you?
You know, like you said, there's not very many deputy directors that are hired. So, you know, if you want me to be involved during the hiring process, that's at the discretion of the board, and I'm fine with that.
Okay. I'm willing to give it a try.
I'm
If-
not sure I am. Oh, no, I'm good with
Give me some, I got something to throw.
it. You do,
And if.
but
you
the
know,
guidelines, said, oh,
Yeah, and like everything, I always view, if we get into it and it truly becomes burdensome, we can change it.
Yeah.
I try to be real flexible.
Well, I guess I still have a reservation about saying the three of us also appoint the deputy directors, but that's my reservation. I like the lines of authority to be very clear.
the lines of authority are clear. And I'll probably be rude enough to remind you, I've got a hell of a lot of experience with a lot of line management.
Well, I can also count, so. Anything else?
No, any miscellaneous? I did have, I will mention it while we're in here, and I can mention it to you guys. I had a complaint come to me because a guy drove his UTV. He said it was a licensed UTV. You can get them switched through our park in Lexington, Riverside. And he got into a conversation with our gal, and it sounds like he was fairly rude. And so the information to me is he was kicked out of the park, and we don't allow them in the park because it's not a public road. So I did ask him, and I said, well, we've had some experience now of allowing them on public roads if they're licensed, set up like a car is supposed to be with your blinkers and all that stuff. If the park board would maybe take another look at that. And so that's a request I sent out to them. Other than that, I didn't have anything else. Okay. We will adjourn.